Hello and welcome. This is the PEMeast Educational Meeting from March 2022 on paediatric shock. This is the second of the two talks we did on the day, entitled Going Weak at the Knees. My name is Dr. Daniel Morel. I'm an emergency medicine specialist who specialised in paediatrics, and I'm also a paediatric critical care transport fellow. I'm also the PEMeast secretary. So for this talk, the main theme of the talk was paediatric cervical spine injury, and we discussed the diagnostic conundrums, assessment and the approach to paediatric cervical spine injury using a case of a 5-year-old who I had seen in the emergency department. In this recording, we'll cover the clinical considerations, the evidence behind decision-based tools, imaging and how to approach the child presenting with neurogenic shock. So, paediatric cervical spine injury is quite rare. So, approximately accounts for less than 5% of all paediatric patients presenting with major trauma. However, in spinal injury, the cervical spine is the most commonly injured area of the spine in children, and that's for a number of reasons, including anatomical development, which increases their susceptibility to cervical spine injury, such as having larger heads relative to their bodies. Their spinal column is more elastic, the cervical spine muscles are weaker, and there's greater ligamental laxity, especially around the atlas and the axis, so C1 and C2, where the ossification centres don't completely fuse until about 7 years old, making them 2.5 times more likely to sustain atlantoaxial injuries. So in the under 10s, the most common cause of cervical spine injury is road traffic collisions, and in the over 10s, it's sporting injuries. But the mechanisms and anatomy of cervical spine injury in children changes with age. So children less than 8 years old commonly injure C2 and C3, and children greater than 8 years old commonly injure C5 and C6, which can be which is in itself a challenge. There was a study done by Baker et al. In the American Journal of Emergency Medicine, which showed that looking at patients presenting with cervical spine injury, and it found that 18% of all patients with cervical spine injury in children were asymptomatic, however were associated with dangerous mechanisms. So the issues when assessing these children is it's a rare but very important diagnosis, a bit like trying to find a needle in a haystack. But obtaining adequate imaging and assessment can be a challenge in itself. You may require sedation, the patient might not be cooperative, it is time consuming, it's resource heavy. And then you've got the radiation considerations of imaging, and whilst MRI can be unavailable or impractical to do. So when assessing these children, what you need to consider is what the mechanism of how they got injured and how and what risk they have put to their cervical spine. So mechanism of injury, what puts you more at risk of cervical spine injuries, axial load, so you're diving off the diving board and hitting your head on the ground type injuries, as it puts a lot of load through your spine. And the weakest point would be your lower cervical spine in older children, and your forced hyperflexion injuries, i.e. your rugby scrum. Others, so high risk motor vehicle collisions, so passenger killed in the road traffic accident, car being rolled over, going at high speeds at over 60 miles an hour, ejection from the vehicle. Another mechanism to consider would be fall from height, so over 10 feet, or injuries associated with non-accidental trauma. But there's also some patient-specific factors that you need to consider. So which will put you more at risk of cervical spine injury. First of which is trisomy 21. So children with Down syndrome have atlantoaxial instability, which affects the bones of the upper spine and the base of the neck. And actually, the joint there's actually, because of the laxity, the space between the spinal cord and the base of the skull and the C-spine can be extremely narrow, especially when they flex and extend. I would encourage you to have a look on YouTube at these videos, because you'd be quite shocked with the amount of movement these children have, or the amount of movement of the spine against the spinal cord. Other conditions, so osteogenesis imperfecta, so these children are more susceptible to fractures, achondroplasia, and rheumatological conditions such as rheumatoid arthritis or juvenile arthritis, and your connective tissue injuries. And then, not to forget, your metabolic syndromes, as they can affect the calcium absorption in bones and cause osteopenia. So what clinical decision tools are there to help you decide who needs imaging and who you can discharge on just clinical examination? So there's been, over the years, there's been development of many cervical spine injury clinical decision-making tools. The most common ones are the Canadian C-spine rules, the Nexus rules, which were developed in the States, and the PECon rules, which were developed in Australia. So going through, the most common one you'll come across is the Canadian C-spine rules. It is recommended by NICE, which we'll go on to later. So you basically go through 3 lots of questions. So if there's any high risk factors, if you don't have any high risk factors, you can see on the flow diagram, if you've got one or any of the low risk factors, and you're able to rotate your neck right and left without any difficulty, then you can rule out cervical spine injury without any imaging. The Nexus study, which was done in the States, used if you had no midline tenderness, no focal neurological deficit, were alert, not intoxicated, or did not have a distracting injury, then you can clinically rule out cervical spine injury. And then the PECon C-spine risk factors were if you didn't have any altered mental status, focal neurological deficit, substantial torso injury, neck pain, torticollis, conditions that predispose into cervical spine injury, a diving injury, or a high-risk motor vehicle crash, you can rule out C-spine injury clinically. Now, the main issues with these the validation of all these rules is that many of them weren't validated in children. So, ironically, the one that NICE used is not the original Canadian C-spine rule studies. They did not validate and did not have any children under the age of 16 years old. In Nexus, only 1.3% of the C-spine injuries presenting were in children under 8 years old, but it does perform quite well in the 9 to 17-year-olds. They both have been retrospectively studied and can perform reasonably well for older children. The PECon C-spine rules is yet to be validated, but in the study in Leonard et al. In 2011, had a 98% sensitivity. So essentially, you can use these rules in context to help you decide how high risk a patient is with cervical spine injury. But it's not binary, and obviously children may not be able to, it may be difficult to assess children, and it may be difficult for them to be cooperative. Torticollis as a symptom in assessing a trauma can be concerning. It can be associated with cervical spine injury, particularly rotatory subluxation of the C1 and C2 vertebra. But typically in trauma, you get ipsilateral sternocleidomastoid muscle spasm, which differs from medical causes of torticollis. But again, would be a consideration for imaging. So what type of imaging is modalities are there available, and what is useful? So plain film X-ray is rapidly available and is rapid and readily available. It's quite sensitive for picking up bony injury, but you do need to have adequate imaging, so the child needs to be cooperative enough to be able to take the views. The radiation exposure with plain film is minimal, but as with the event of CT scanning, more and more people are interpreting C-spine X-rays is becoming a bit of a lost art, and some people may find it hard to interpret. My advice in these sort of circumstances is that if available, which you should do depending on your radiology cover in your hospital, be able to talk to a specialist to see what they think about the imaging. CT scanning, again, is quite readily available. It's fairly rapid, and it's quite definitive for ruling out bony injury. However, there is a high risk of radiation exposure and exposing the child to potential to things like thyroid cancer. MRI is the most detailed type of scan, and it's sensitive for both bone, soft tissue and cord injuries, as well as bony injuries, but it's not readily available 24/7. It's very slow, and as in the scan itself can take up to 40 minutes to an hour to complete, and you're likely in that sort of time to have the child needing a general anaesthetic in order for you to complete the scan. So what do NICE recommend? So NICE recommend actually performing MRI scans if you've got a child with spinal cord injury indicated by the Canadian C-spine rules, or spinal column injury indicated by a clinical assessment or abnormal neurological signs. Plain film X-rays can be used in children who don't fill the criteria for MRI scan, but you are still suspicious following clinical assessment, and that if the plain film X-rays are inadequate or you're hard to interpret, you can ask a consultant radiologist to see if further imaging is needed on your clinical suspicion. So for NICE, in terms for C-spine evaluation and imaging in the department, as we said, they recommend the Canadian C-spine rules, and this is the East of England Trauma Network Tempo Guide for assessment of C-spine injury in children. So what they go through is two lists of criteria. The list on the right will refer to CT imaging, which we'll go through according to NICE. But if the patient cannot rotate their neck, it's not safe to assess their range of movement, they've got midline neck pain or tenderness, plus a dangerous mechanism as defined as a fall for more than 1 metre or 5 steps, an axial load, pedestrian versus motorised vehicle, or road traffic accident involving rollover, ejection, patient on a bicycle, or there's passenger death. Or if a definitive C-spine diagnosis injury is urgently required prior to surgery, then they recommend using using plain film X-rays. In patients who are GCS less than 13, been intubated, plain films are inadequate or technically difficult, there's clinical suspicion of C-spine injury despite normal X-rays, or the patient's being scanned multi-regionally, then CT imaging should be requested. Which is in line with what the NICE guidance says for selection of imaging of cervical spine injury in patients who have sustained a head injury. So if they've had a head injury and if they've got any of this criteria, then they should go for a CT. If they don't fulfil the criteria but they've got neck pain or tenderness and a dangerous mechanism, then you should consider C-spine X-rays. This is because in head trauma, there's 10 to 20% of head trauma is associated with C-spine injury, especially in severe head trauma. So when this was brought in, the Peruki network looked at all the images. So it looked at how CT scans, how many CT scans were done prior to the guidance coming in, and how many CT scans were done post the algorithm in paediatric patients. So what we looked at is so prior they looked at the sensitivity of scans and how often the scans were being performed. And what we found is that cervical spine X-rays had quite a good sensitivity of about 90%, and cervical spine CT scans, none at all saw 80% of children who were suspected of having C-spine injuries, who underwent CT, didn't have any injury found. But there was a lower proportion of children being CT'd, undergoing CT scans since the NICE algorithm was applied. And they had an 80% detection rate of C-spine injuries, with the other 20% being picked up on MRI. And this is due to the phenomenon that children are more likely to get, which is spinal cord injury without radiological evidence. So you have a normal CT scan or normal X-rays. So the caveat to this is that even if you've got normal imaging, if they've got ongoing neurological deficits, as discussed, we went through my case that we had, that you need to consider that the patient will need to go under MRI imaging before you can rule out any significant injury, and that would be you would consider doing both the head and the spine. So how do you approach the patient who's presented to you with a C-spine injury with neurological deficit? So the American Spinal Injury Association have done an international standard for neurological assessment in spinal cord injury. So this diagram is available on the internet and should be used to assess the patient prior to you talking to either a spinal surgeon or a neurosurgical centre. And it's a standardised way of assessing the motor level and the sensory level of a patient with a spinal cord injury. So the sensory score is 0 for absent sensation, 1 for altered sensation, and 2 for normal sensation. And you mark it from the level of highest feeling. So say, for example, you assess a patient and they can feel their level at T3 on their right hand side and T5 on their left hand side. Then you will say their sensory level is T3, so you always go for the higher level. Motor scores scored between 0 and 5, 0 being total paralysis and 5 being normal movement, and a 3 being active movement but against gravity. And then you've got a little section to write comments about reflexes. And this is a standardised way of talking to other neurosurgical centres where they'd be able to understand the clinical signs and symptoms that you've got in front of you. So this is available on the internet, and I would recommend, if you're assessing someone, printing this off and going through it. Now, you couldn't really talk about spinal cord injuries without talking about spinal cord syndromes. So there's a couple of spinal cord syndromes that you may come across. The first one being in the picture is central cord syndrome, where you get loss of the centre of the cord. And the symptomatology is that you get your upper limbs are worse affected than your lower limbs, and that's because your upper limb nerves that supply that go through the cord are more central compared to your lower limb ones, which are more peripheral. You will get a varying sensationary loss, so what we call typography arrangement, which is basically means patchy. So you might get a patch of sensation loss in one area and another in a different area, which may not make neurological sense. And the most common way of causing this is a hyperextension injury causing vascular compromise. So the classic in adults is your elderly patient who's fallen onto their face and they've got spinal stenosis, so it causes vascular compromise and edema of the cord. Anterior cord syndrome, this is when you get essentially get injury to the anterior cord, which is usually an infarction of the anterior spinal artery territory. So you would get paraplegia below the level of the injury with loss of pain and temperature sensation. You would get your posterior cord sensation would be intact, so your vibration and proprioception sense. And unfortunately, these patients tend to have a very poor recovery prognosis. And then the last one is your hemisectional Brown-Séquard syndrome. This is when half the cord's been taken out, classically from a penetrating trauma or stab wounds to the back. And you will get ipsilateral motor loss and proprioceptual and vibration sense loss with contralateral loss of pain and temperature sense. And that's because the way the pain and temperature sense loss do not cross they cross at the level of the cords rather than the level of the medulla, which is in where you get your motor and your proprioception and vibration sense loss as they cross at the medulla. And then you got these terminology. So you've got what's the difference between spinal shock and neurogenic shock. So spinal shock is a hemodynamic phenomenon where you get loss of vasomotor tone and sympathetic innervation to the heart. So the injury to the cervical or thoracic spine, so approximately from T6 above, can cause impairment of the descending sympathetic pathways. And you'll get loss of tone, vasodilation of the viscera and peripheral blood vessels, with resulting in pooling of blood and hypotension. And then the sympathetic innervation loss to the heart will cause bradycardia and inability to mount a tachycardic response into the hypovolemia. So you need to be cautious in these patients you suspect have got spinal injury or who are hypertensive and are not fluid responsive, as judicial fluids may cause pulmonary edema. You also will get a loss of temperature regulation, and neurogenic shock is not transient. Spinal shock refers to the process where you get flaccidity and loss of tone and loss of reflexes immediately after the spinal cord injury, and after a period of time spasticity will ensue. So you get decrease in reflexes, loss in sensation and flaccid paralysis below the injury, and it's usually transient. Now, often why these terms get confused is that actually both of them can occur at the same time in the same patient, but it's good to know what the definition is for either of these syndromes. So how do you manage, or what are the management considerations in cervical spine injury? Well, if you take an ABCD approach, firstly, the airway. So the airway is potentially going to be difficult. Patients will need to be lying flat for alignment of the cervical spine, and for obvious reasons, will be immobilised and won't be able to move their cervical spine. So this will potentially make any intubation difficult. And also, because they're lying flat and in trauma, you may get decreased gastric emptying, and they'll be more at risk of aspirating. Breathing, so these patients, especially in high cervical spine injury, the phrenic nerve comes out of nerve roots is C4, C5, C3, 4, 5. So you potentially may get loss of the phrenic nerve innervation and movement of the diaphragm, which will cause hypoventilation. Also, the actually just lying flat will make you hyperventilate. So these patients are at risk of becoming obtunded and hypoxic, and may need ventilation support or intubation. Circulation wise, so as we just talked about, you get loss of vascular muscular tone, resulting in hypotension. So actually giving fluids may not be, especially if there's non-responsive, is not the best thing to do. And actually you need to peripherally vasoconstrict with vasopressor drugs, so either phenylephrine or noradrenaline, in order to maintain the vascular tone and maintain your mean arterial pressure. So the goal is, and once the injuries happen, a bit like neuroprotection with brain injuries, is that you want to prevent any secondary neuron loss due to hypoxia, hypotension, hypoglycemia, or further movement. So you need to target a mean arterial pressure similar to what brain injuries would be. So for example, if the child's under 2, you need to aim for mean arterial pressure between 50 and 60. If they're between 2 and 6, a mean arterial pressure of 70. If they're over 6, a mean arterial pressure of 80. And if they're over 13, a mean arterial of 90. You need to prevent hypoglycemia, so these patients will be nil by mouth whilst they wait a swallow assessment. So you need to consider NG feeding, or not in the immediate term, but certainly dextrose and IV fluids to maintain your glycemic control. And they will need potentially you need to prevent any cause of hypoxia, so making sure they're adequately ventilated. So neurological wise, to prevent further cord ischemia, you need to restrict their movement, and that might consist of an external fixation, so a halo device, before they go to finish the surgery. And finally, these patients will need to have spinal precautions, so generally they'll need to be lying flat. You need to make sure that they spend minimal time on hard surfaces. So as soon as these patients are identified, you need to get them on a specialised pressure mattress. Need to be log rolled with multiple people whilst nursing to prevent pressure sores. And then you need to consider the toilet requirements. So catheters may be considered, and certainly rolling and cleaning are a must to prevent pressure sores and secondary infection. So in summary, paediatric cervical spine injury is a rare but significant diagnosis. So remember your risk factors, so trisomy 21, your metabolic diseases and your musculoskeletal diseases. The NICE guidelines are a guide but not a rule, so you need to balance the risk of someone, the risk of missing an injury versus the risk of putting them through potential sedation and the radiation risk, which is a challenge. Neurological symptoms are not binary, so assessment can often be difficult in these patients, and patients can need to be cooperative. And actually having a period of observation and sharing the risk assessment with the caregiver may be helpful in these circumstances. Patients need MRI imaging who are still symptomatic despite negative plain film or CT imaging, so that's remember your score. And neuroprotective strategies and high cervical injuries are part of the immediate management before definitive fixation. These are the references. Thank you for listening.